Well, welcome back to the podcast for Cultural Reformation, and this is a special edition of our podcast today because joining me in the studio is not just your usual host, Ryan Eras, but we also have Dr. Ted Fenske, who is a cardiologist in Alberta and a fellow of the Ezra Institute, joining us from Alberta. Welcome, Ted. Thank you for being with us.
Good morning. Nice to be here. Thank you very much for inviting me.
And also Dr. Peter Saunders, who is a surgeon, and he is the CEO of the Christian Medical and Dental Association internationally. So it's the International Christian Medical and Dental Association, and he is based in the UK, although I think he is a Kiwi. Is that correct, Peter?
Quite correct on both things. Yeah.
So we'll forgive you.
Quite correct
for
on
that.
both things. Yeah.
Now, it's a special privilege for me because I've actually known both Dr. Fenske and Dr. Saunders for some years now. I've had the privilege of working with Dr. Peter Saunders at the Wilberforce Academy in England, and to benefit from his teaching and lecturing and articles over the years. And also a long-standing friendship and working relationship with Dr. Fenske as well in Alberta, who I've known now and his family for many years, and benefited so much from his work and his articles and ministry also. So we're so grateful that both of you as medical professionals in the Christian community have been willing to join us today. The part of the reason that we thought we'd do this special podcast is that I sort of wandered in where angels fear to tread a few days ago, actually published on Friday last week. People were asking us as an institute what we thought about the current crisis, and it's very difficult to just say nothing as a think tank and a worldview training organization. And so some of my initial musings on the crisis were published in an article on our website called COVID-19 Calamity. And we experienced an unexpected spike. We don't usually get that. We're not first responders as an organization. We are a think tank, and we tend to do long form articles, and our focus is worldview. We don't typically respond to things going on in the media in this sort of situation. So we were not expecting any more than the usual volume of traffic. But I think we've guessed that now, because everybody appears to be stuck inside with little more to do than forward articles to one another.
And there's only sort of one variation of this same headline. Everyone's sort of reading from the same sheets.
Right. So we wandered into it, and the focus of my article, and I know both of you, Peter and Ted, have read it, was to talk about how God might be speaking through and in this whole situation, the elements of God's judgment in this situation, both in terms of epidemics in Scripture and the response to them. And then I raised some questions about how we are responding as nations, and what might also be the fallout of that response. Probably the most controversial element in my article was I cited a few statistics from Europe. I also cited a few outliers, from Stanford University here in America, and a German professor as well. And based on some very faithful counsel that I've received from medical professionals, both of whom are on the line here, but also others, I've moderated some of that material in there, taken some of it out in the first article, just because I don't want to mislead anybody, and I'm no infectious disease specialist. So there's differing opinions. Lots of articles are flying around everywhere. So we thought, well, in terms of the most controversial aspects of the article, it'd be better to talk to faithful Christian professionals looking at all of this. So let's get into it in general, but we wanted to focus a little bit more on the kinds of questions that Christians are now asking about the response in light of the crisis. And maybe we could start here with you, Peter, with our first question. in terms of just helping us understand, helping our listeners understand the health implications of COVID-19, maybe just giving us a brief description of it, what people are actually dealing with. I've read recently that there may be 2 strains of it out there, S and L, I think, although I could be wrong, I'm going from memory there. And help us just understand right now what are the implications for people who are suffering with it, and who are the people who are most vulnerable to this virus?
Okay, well, as we know, the virus began in Wuhan in China back in December last year, and it's gradually spread all over the world so that now over 200 countries and territories are involved. And the focus of the worst activity now is Western Europe and the US, but the numbers are increasing everywhere. What makes this virus particularly dangerous is that there is no treatment, there's no vaccine, and it is reasonably infectious, not as much as measles or chickenpox, but as much as the flu. And it has a relatively high mortality. We're not sure exactly how high, but we think it's at least 10 times more dangerous than the flu in terms of ending people's lives. It may be up to 30 times. The World Health Association is saying that about 3% of people will die. That those figures are probably higher than the actual figure. It's probably closer to about 1%. In terms of susceptibility, the people who are elderly, greater than 60 years of age, but particularly 70 years of age. So the figures that came out of China initially showed that people in their 60s, 3% of them would die, 8% of those in their 70s, and 15% of those in their 80s, based on the Chinese figures. And from China also, they said that 4 out of 5 would have relatively minor illnesses and escaped hospital, but 1 in 5 would need hospitalization, and of those, 1 in 4 would need not just oxygen but intensive care. So it's a serious illness. We don't quite know how bad yet, but the figures now, we're probably going to cross 1 million cases today, although we think worldwide, but that is a huge underestimate, we think, because many countries are not testing for the virus, and so the numbers are underrepresented. But what is significant is the number of deaths will probably pass 50,000 worldwide today. But the rate of increase is what is startling. So it's about running on about 10% increase of deaths per day at present. So 50,000 today, if it carried on at this rate unabated, would mean 100,000 by the 9th of April, 1 million by the 3rd of May, 2 million by the 10th of May, 5 million by the 20th of May, 10 million by the 27th of May, and so on. Now, a lot of countries around the world have implemented lockdown or social distancing, and we think this is going to have a huge effect in ameliorating that rise. But at the moment, it's early days, and we simply don't know. But to give you an idea of the rise, in Britain, we had our first death on the 5th of May. It was 1 or 2 deaths a day for about a week. But there's been a steady increase since then. And on the last 2 days, we've had 500 deaths each day and a total of almost 3,000 deaths so far. So Britain is one of the worst countries now in Western Europe. I think the other thing that makes this difficult to deal with is that it is relatively easily spread either through physical contact or through coughing, droplets, aerosol, that kind of thing.
Yes. So just drilling down a tiny bit more into that, Peter, maybe you could help our audience just understand the difference between the denominator and the numerator, which is part of the challenge in assessing the risk. So the denominator being the number of deaths being recorded. A lot of material is coming out now from professionals talking about the problem of the numerator, which is we just don't know at this point how many people are infected. In fact, a new study just came out of the University of Oxford, which suggested that maybe half of the UK population has been infected already. And the sort of difficulty of knowing the numerator. Can you help us understand just a little bit more about the relationship between denominator and numerator and how that might affect predictions, and also the kind of models that we're seeing coming out from politicians? So people here in Canada might be watching CTV one evening, or they'll be watching CNN another evening, and President Trump's team offering a model, and then they're going to hear an expert 10 minutes later coming back saying, well, none of these models are, usually all models are wrong, and there are so many uncertainties, we can't be sure about how these models will play themselves out. Maybe you could just drill down a little bit more into the relationship there between denominators, the numerator, and these various models that people are hearing every day.
Yeah. So the one thing we do know more or less for certain is the number of people who've died in Western countries who have been positive for the virus. So that's what we're calling the numerator. And then what we don't know is the number of people who've been infected by the virus. And the difficulty with that is, first of all, that some countries aren't testing many. So in Britain, we're only testing those in hospitals. Not even frontline healthcare workers are being tested. But in other countries, they're going after all of the contacts, and so they're getting a much better, more accurate indication of how many have been infected. The other problem is that some of the cases are what we call subclinical, which means people do have the infection, but they don't have any symptoms. And the problem for epidemiologists here is that we don't really know the mortality of a virus like this until well after the event, when we can do what are called serological studies, looking at who carries antibodies to the virus and has therefore had the infection. And they can't be done until after the whole thing settles down again. And so this is why initial estimates of how lethal viruses like this are always tend to be overestimates of the true number because of the uncertainty, as I say, both about testing and about the number of subclinical infections that there've been. I think the closest indicator we get to look either at populations where they've gone after and tested everyone who's had symptoms and every contact. Some of the East Asian countries have done this. Yeah. Or to look at a closed situation like, an ocean liner on which everyone's been affected and seen how many have died.
Yeah, the Diamond Princess. Yeah.
That's right. And that was about 1%. And it was a predominantly elder population. So this is why some people are saying maybe it's lower than 1%. If you look at the Chinese figures, it's closer to 3%. But the other problem is that deaths lag infection. So for those people who are unfortunately going to die from this, it's an average of 14 days after their first symptom that people die. And so you've got a lag phase. So when the epidemic is running fully in a country, you get an overestimate the other way, if you like. So you can be lulled into a sense of security, thinking it's not that serious, but actually many of those infected are eventually going to die in the next 2 weeks. So that's what makes it so difficult. But what we do know is that this is a serious virus.
Yeah. So before we come to Ted, with thanks for your patience, Ted. Just one further drill down question in this, Peter. One of the things that you find some of the researchers, some of the articles talking about is the issue of excess mortality. So you're in the UK, and on average in the UK, apparently about 150,000 people die between January and March, and the Imperial College researcher, is it Neil or Niall Ferguson, who's been the one speaking dominantly in the media there, and gave us the initial estimates of 500,000 that possibly that have been revised down if certain measures were taken. He's said that it's possible that a half to a third of the people who have been dying would have died anyway. So the question of excess mortality, if you've got, for example, 153,000 people dying every day in the world anyway, how do researchers and the epidemiologists and the virologists sort of work through the fog of how many of the people that are dying would perhaps have died of a bad cold or of influenza or of something else anyway? When do you think we'll know sort of reasonably accurately what the excess mortality is?
Well, it's important to understand the difference between dying with something and dying of something. Now, for example, if you have cancer, but then you get pneumonia and you die a lot quicker from that than the cancer would have killed you, then you're dying with cancer, but of pneumonia. Now, people who are dying from coronavirus are almost entirely dying of or from coronavirus rather than with it. And the reason for that is because the time scale from first symptom to death is only 14 days. But the question you're asking, I think, is given that a lot of these people are elderly or vulnerable, would they have died anyway in the near future? And it's about timescales, really. The data that's coming out of the UK now suggests that of those who are dying, about 10% the figure I'd seen, would have died in the next year after it. So the question is, that of course means that 90% wouldn't have. So people even in their 70s or 80s, or for me in my 60s, still have a reasonable life expectancy on average of several years. So it's definitely a life-shortening illness, because it affects those who are most vulnerable in terms of age or associated diseases. Often it won't shorten life, obviously, nearly as much as it would for a teenager or someone who was middle-aged or a child.
Yes. I'm looking at an article.
We need to be very clear. It is coronavirus is the cause of death for almost all people who are dying of it. It is the immediate cause of death.
Yes. So I'm looking at an article here from The Critic in the UK. It was published just a day or so ago, and I don't know how accurate these figures are, but the average age of those who have died from the virus in the UK, this article is claiming to date, is 79.5 years, and the average life expectancy in the United Kingdom currently is just short of 81 years. So you're saying that it does appear to be a disease that is primarily impacting the elderly, and those people who are getting it do appear to be dying from the virus, not just with the virus.
Yes. If you take the figures you've just given me, if the average life expectancy is 81 years and the average age of people dying is 79, and I'd say those would certainly resonate with what I would say would be true. The point is that if you take 79-year-olds, their average life expectancy is not 81. It's substantially higher than that. And that's because people who've got to 79 are a subset of the population who will then generally live longer. So, yeah. So the point is, if you're talking about our parents or grandparents or great grandparents, however old we are, we're talking about something that is going to shorten their lives It might just be by months if they're already dying from cancer or serious heart disease, but more likely it's going to be years, but less likely decades. So we're looking at something that they will die from much earlier than they would have otherwise, but they are a subset of the population who are more vulnerable to this kind of disease. And this is what makes coronavirus different, say, from SARS, which was no respecter of age, but makes it more like flu for which elderly people are more vulnerable. Yeah.
Yeah.
So coming to how healthcare providers, and Ted, you can feel free to comment on anything that you've heard so far, because I'm coming to you now. So one of the things that I think Canadians especially are asking themselves is how is the health service, how are our hospitals coping? What's happening on the ground in the hospitals right now. We don't have all that many recorded cases. There's very little testing, as far as we know, going on in Canada. And I don't know, Ryan, if you can pull up the latest figures on death in Canada. But one of the things that has been stressed is that we don't want that Canada's health services provincially are stretched anyway, and the concern is a big rush on beds and so forth in view of this virus could be catastrophic. I'm looking at the figures now. Coronavirus cases just under 10,000 at 9,731 known, and 129 deaths in Canada, with about 1,700 plus already recovered. Ted, just give us your thoughts so far on the discussion, and then tell us a little bit about your experience in Alberta. I mean, and what you know about across the country. I'm sure medical professionals are talking to one another. What's happening? Are you seeing beds flooded in Alberta? Are hospitals overflowing with COVID patients? What's actually happening?
No, thank you, Joe. Well, certainly the landscape of the hospital is night and day different than it was before this pandemic. Our hospital's not overrun currently at all. We have capacity presently. We have some cases in our ICU in the hospital that I'm working at. But our concern, of course, is as Peter was talking about, where we are on this curve and what's coming. And the concern is that in the next 2 to 3 weeks or so, numbers may be increasing. And as you mentioned, the system's already stretched to begin with, and this has really affected every part of the healthcare system, from our surgeries and the admissions to cleaning and food services and every element. There's no real thought or consideration happening administratively. It doesn't take into some kind of accommodation of how the virus is potentially going to play itself out here. So as a result, in the healthcare professional realm, there's general fear and angst about people's personal safety, and frontline workers are concerned about their own protection and going forward, and also the possibility of taking home virus to family members who may be following quite stringently the recommended social distancing, hand washing, etc., but still taking this home, because really the healthcare worker is a risk factor. I'm a risk factor when I come home to my kids, and so this is it plays on your mind. One thing that we accept a certain risk. We go into medicine, and I've had some opportunities to be working abroad, and the risk that one takes on, but you don't really want to expose your family to that risk either. So these are what's playing in people's minds, I think, and the concerns, I think, are we won't know until this whole thing settles just how if this is appropriate or not. But certainly this is how people are feeling.
Right. Just on risk to healthcare workers and doctors and so forth, I'm not yet aware. I may have missed something. I'm not yet aware of a frontline medical worker dying in Canada as yet. from the virus. Is there if a medical professional is treating somebody with the virus, is there in your hospital, for example, is there an increased risk of negative health outcomes from repeated exposure to it, or is it the case that if you've been exposed to it once and you're either asymptomatic or only mild symptoms, at that point are you resistant to it? Has your body then built up antibodies? What do we know so far about that and the degree of risk to health workers?
Yeah, as Peter was mentioning, that information will come. As we look back on this, when you're in the fray of it all, those are all question marks still for us as well. And since in my own experience, since the AIDS epidemic of the 80s when I trained, and the development of the universal precautions, that has brought a certain protection for all healthcare professionals then in the medical field in terms of reducing risk. So we have fairly stringent infectious control measures that have become heightened now in this time, just because of the how more easily spread perhaps this virus is than other issues. For example, the AIDS virus, bloodborne, and so there is this concern, and it would stand to reason that the more exposures one has, the higher the potential for infection. And this was seen, for example, in other, the Ebola crisis in 2014. The physicians and the healthcare workers that had repeated exposures, their risk went up. We've had no deaths, of course, but you have had some of our staff at our own hospital who are positive, and the problem here is that because they're positive, they had this wide web, if you like, of interaction with other staff members. It's really it's forced all these people then to go on a quarantine, and so it really affects on the workload for us, because now we have reduced numbers, and so whole areas of the hospital now are shut down, if you like, because of one person being positive, and then because of their shift work and contacts, now all those people have to self-isolate, and so that's also.
And is that for a 14-day period that they have to? Is it sort of 14 days? Yes.
Well, we can test people sooner than that, and so but it still takes about 72 hours or so to get a turnaround, even on a healthcare professional of a result. So one of my colleagues was concerned with symptoms and had to go through a 2-week isolation.
On the Canadian landscape, then, Ted, specifically, one of the questions people have is why is there not? Maybe you can help us understand what the medical profession is saying about this. Why is there not widespread testing in Canada? We're a relatively small country in terms of population, just over 30 million. We're much more like one of the smaller European nations, not like our massive neighbor, the US. And we've got this at the moment relatively limited number of cases, and so that our understanding in Canada of the denominator numerator relationship is very poor, and we've got these national lockdown quarantine measures. Is there a particular reason that you're aware of that has that means that we're not testing and isolating the vulnerable? Is there a particular reason why in our health services across the country the testing doesn't appear to be being emphasized?
Well, I'm sure this would be the ideal, and if we had kind of a head start warning on this, perhaps things could have been ramped up to the point where this could have actually been in place. But the reality is it comes into an already busy, stressed system, and it's just a matter of numbers. So presently, even though we're not testing everybody, we're testing a lot of people, and our blood collection services is presently overwhelmed. We're having to not do other blood work on patients just so that we can free up space for the COVID-19 testing.
Right. So that's really helpful. So that brings us to another question, I think, gentlemen, which we'd like to sort of pivot to now, having sort of got a good sense of the situation on the ground as you see it, and the risks associated with the virus. One of the concerns that I raised in my article, and I'm seeing more and more articles in the last week coming out and raising the same concerns. For example, the National Post here in Canada has just raised a whole series of questions, not just about the rates of infection and the death rates and the unknowns about the risk factors that you've been talking about, and the challenges in ascertaining that, but the actual fallout from the measures that are being taken. And one of the questions that I did raise as a total layman, I recognize that as soon as you stick your head over the trench on anything like this, you're risking getting it shot off. But I did raise one or two questions, and I'd like to think slightly earlier actually than some of these critics that are writing now in the National Post and in the British journal The Critic, that there are actually health outcomes, potential health outcomes that result from the current measures that are being taken. And that's one of the questions that we wanted to raise with you both, and perhaps we could start with Peter. I raised the issue of the implications of a very sharp economic contraction that could be more severe than the 2008 crisis. For example, we know from studies, one that was done by the University of Oxford, published in the British Journal of Psychiatry, of a massive spike in suicides in North America and in Europe after that particular crisis, because of job loss, home foreclosures, the debt, anxiety, that a huge spike, over 10,000 additional excess economic suicides, they were saying. And some of these articles are talking about 4-5% higher rates of suicide. Just one issue, poverty. We're all aware, because of our global economy, the interconnectedness of the global economy now, that when the West decides to do something, and we offer our very big bailouts and stimulus packages to our relatively wealthy societies to help ameliorate the impact, countries in Africa and Asia that are deeply impacted by this, and then try and copy Western measures. We're already seeing in India and parts of Asia tremendous suffering ensuing from all of this. So there's the economic collapse, the job loss, the health implications for people who are unemployed, the elderly who are isolated. I talked about the fact that it's I think pretty well understood in medicine that even if you can articulate your purpose in life, you've got an increased life expectancy, and if you are socially interacting with people and so forth, you increase your life expectancy. Not being in poverty increases life expectancy. So one of the concerns that I think it's important for us to understand in terms of health, as we look at a health disaster with the virus, is what might be the ensuing health and well-being disaster that follows on the heels of this. And so countries like Sweden have been discussing that and talking about that, and are taking different measures. I'm sure there are different issues for them, and Germany and other European nations who've gone a slightly different route with testing and so on. But talk to us, Peter, maybe you first, a little bit about what might be some of the health outcomes, both in the West and then in other parts of the world, from the measures that are being taken. Is it possible, is it conceivable that the fallout could be as bad as the virus itself?
I think what we need to understand before we ask this question is the background to what's happened in other parts of the world, because the trajectory of this virus is very, very different in the US and Western Europe than it has been in East Asian countries. And what happened in East Asian countries like Singapore, Hong Kong, Japan, Taiwan, South Korea, and indeed China itself, is that because of their past experience with dealing with SARS, they got onto this very, very quickly, and they instituted a very rigorous program of testing for the virus, tracing all close contacts, and then quarantining. And this was achieved in the communist country of China, but also in the East Asian democracies. And the result of that was that they had very, very few cases and very few deaths in comparison. Now, if you're going to compare countries, the best way of doing it is by talking not about deaths, but about deaths per million population. And the number of deaths per million population in China from coronavirus was two deaths per million population. But in Italy and Spain, there have been already over 200 deaths per million population. And so the problem we have in Western Europe and the US is because we didn't institute an early rigorous test, trace, and quarantine procedure because we just weren't ready for it, the virus stole a march on us and got away on us. And that's why we've had these radical lockdown policies enforced in Western Europe. Now, the thinking behind that is that now that it's out of control, what we have to do is just flatten the curve so that we can deal with the cases that we're going to get and hope that we'll be on top of it in a couple of weeks or so because of social distancing and quarantining, and then we can change our approach. So in the UK, for example, the focus was all on building capacity in the health service. So final year nursing and medical students were recruited onto the front line. They brought back over 20,000 retired doctors and nurses. They redeployed people from other specialties and trained them. They produced another 4,000 ventilators. We put up a 4,000-bed hospital in London and other centres and so on. And that's all aimed at trying to deal with the problem. The problem we have in the so of course, as you're absolutely right in saying that all of these lockdown measures will have a huge effect in terms of businesses going out of business and in terms of the effect on people's incomes and livelihood and mental illness associated with that. These things are largely unmeasurable at this time because we don't know how long this lockdown is going to go on. But of course, as you alluded to already, when we look at the developing world, what we're seeing tragically is a copycat of not of the Eastern Asian model of test, trace, and quarantine, because it's just impossible, I think, to do that. They haven't got the testing kits and the technology and infrastructure. So we're seeing this reflex lockdown on everything, which is having absolutely devastating effects. Now, we hear tens, if not hundreds of thousands of migrant workers in India who are having to walk hundreds of kilometres home because there's no public transport. Every interstate border is closed. We're getting reports of the police beating up patients and medical staff going to hospital for breaking the curfew, and people arriving with injuries as a result. And we're seeing similar reflex lockdown procedures in Nigeria is another example. So yes, there's no doubt that the effects of the reaction are huge. I think the two questions are, in Western Europe, did they have any other choice but to do that, given the fact that the virus stole a march on us? And I guess the other big question is how long it's all going to last, because if this goes on for months and months, it will completely destroy economies. You know, we can see that. And we think a far better approach in developing countries would have been what we call green zoning, which is to take all of the vulnerable people, the elderly and those with other chronic medical conditions which make them more susceptible, and put them in houses, streets or communities where they're protected from the rest of the population. Because remember, as we've been saying, the vast majority of people who catch coronavirus will have a relatively mild or moderate illness that they'll get over and will then be almost certainly immune to it after that. It's the vulnerable ones who need protection. And if we had a policy in developing countries that involved red zoning those who are affected, so you separate them from others so they can't pass it on, but then green zoning the vulnerable so that they're protected from the virus in the general community, would have been far better than this reflex massive lockdown, which is having huge effects. The treatment could be worse than the disease.
Yes, that's very helpful, Peter. Thank you. And Ted, this whole question of herd immunity and how this situation might be best handled in Canada going forward. I mean, Canada is a very, very large country. It's the second largest landmass from just a geographical point of view on Earth. The people are, compared to Europe, very spread out. Of course, we do have a few big cities, Toronto, Montreal, Edmonton's pretty big too, but not quite as big. But the situation, is not quite the same as even take a country like the UK, where Peter is, where I'm from originally. Is over 60 million people, relatively small island. All those millions of people in London alone. Just speak to this whole question that sort of Peter's alluded to a little bit there about how eventually, or perhaps hopefully sooner rather than later, we can get to a point where we're actually just trying to protect the vulnerable and the sick and just build up some herd immunity in the general population that's only going to experience a very mild or asymptomatic response to this virus.
I think in that sense, Canada has a certain advantage because we do have a large country. Of course, most of us live pretty close to the 49th parallel, and there is natural crowding that we have, but certainly less so than other parts of the world. Just to build on what Peter was saying, though, in terms of the impact of this going forward, we know already before this crisis the impact of loneliness, and we know already the concern about the elderly and how they're more prone to all sorts of problems from mental health to cardiovascular compromise in loneliness. They're already tend to be on the lonelier side, and this is just going to augment that whole problem. And so this is a real concern, just to add to the economic and other issues that you were mentioning. In terms of herd immunity, this again will be something that will develop, I imagine, and we'll look back on this, and it'll be a historical moment in time. Of course, right now, we're in the fray of it, and it's much harder to consider those things.
Ted, it seems also the case that and Peter may want to comment on this too, that the countries that have younger populations, where the average age is younger, places like Sweden, but other places in Asia too seem to be faring better. I don't know where Canada is in terms of our average age of population, and I don't want to draw one-to-one conclusions about these things in terms of the hand and the work of God in all of this. I think it's dangerous to say this happens because of this specifically and that happens because of that specifically. But is there anything here that if we've been in, some Christians would say, something of a culture of death for a long time? We've been killing our younger population through abortion. And of course, even more recently in Canada, euthanasia, we haven't seemed to be that caring about the elderly either. But it does seem to be the case that this particular disease, unlike the Spanish flu 100 years ago, is really impacting the elderly, and that actually having a much older population and more of a lack of young people. I mean, it's being handled. Interestingly, primary schools have been kept open in Sweden. I'm encouraged to hear you talk about how we should be thinking about and reflecting on the impact on the elderly in a country that has recently opened the floodgates on euthanasia, and as you know, the government's even been talking about expanding it. Um, how can we minister to the isolated and the elderly in this sort of circumstance?
I think, here we have, as a Christian community, a real opportunity, and this is, I think, where we're called to look for the opportunities where we can be the Lord's hands and feet, and bring salt and light into the issues at hand. Going along with the governmental concerns, of course, and as per Romans 13, but to say, okay, what can we do here then to try to mitigate some of this, at least the lonely factor, if not the actual viral spread. And I think there's a real opportunity here for us to pick up the phone and make those phone calls, or Skype, or FaceTime, or Zoom, or what have you, virtually, and even to be able to try to speak into these people's lives. And I know in my practice, we've really curtailed any kind of clinic, or all of our testing is turned almost to zero. But as a result, then I'm phoning my patients, and it's quite a delight to one, hear that they're home. Everybody's home right now, so it's quite easy to get through to everybody. But secondly, they're quite hungry for conversation, and to be reassured about their particular symptoms they may have, about their heart, for example, and to hear plans forward, and just to have that kind of contact. And I think there's a real blessing here, that one can be a certain balm, if you like, over the telephone line. And I think we should not neglect this as a Christian community.
Peter, thank you, Ted. Peter, you may have something to add on this, because I know that I've heard you lecture many times on the issues of abortion and euthanasia, and concern for both the unborn and the sort of anti-family agenda that we've seen in the West over many years, and also the disregard for the elderly. I've been finding, and it could be just me, but I've been finding that some of the talk of politicians has really stuck in my craw over recent days, as they talk about, the Mayor Cuomo, for example, in New York, about you can't put a price on life. And people criticizing anybody raising the issue of potential health fallout for all of this, because you can't put a price on life. There's another discussion there anyway, of course, because actually in the decisions we make about medicine all of the time, we're putting an implicit price on life. But are you struggling at all as a surgeon, as a medical professional, but as somebody who speaks a lot on the ethical issues? Are you struggling with some of the hypocrisy that suddenly we're talking about the value of life, but in our attitude towards the unborn and the elderly and the vulnerable, our culture, until it sort of feels threatened itself by a virus, has seemed fairly careless about some of the most vulnerable sectors of our society?
Yes, I think what's interesting is that, of course, we're living in the West in a post-Christian society, and we're living, really, I would say also in Romans 1 terms, we're living in an end-stage culture. So we know in history that civilizations rise and fall, and that their rise and fall has a lot to do with the behavior of the individuals. We understand that in biblical terms, in terms of God's sovereignty over the rise of fallen nations and his judgment on nations in history. And I think we see this interesting mixture, because on the one hand, everything that's good in the West that we treasure comes out of a Christian legacy, the legacy of Christianity and its profound influence on our culture. And so much of medical culture is based on this Christian idea of respect for life. Now, where does that come from? Well, it comes from Genesis 1:27, that we're made in the image of God and therefore incredibly precious. And it's the the sixth commandment, you shall not kill, is directly linked to that idea of being made in the image of God in the post-flood narratives in Genesis chapter 9, verses 5 and 6. So on the one hand, what we're seeing, I think, is that we're witnessing people reverting to their Christian legacy, but not knowing where it's come from. And so we have all this talk about we must protect the vulnerable. Every person is important. We've got to do our best for everyone, even if they're elderly and sick. It doesn't matter. Even if we wreck the economy to do it, we're going to look after them. And I think that comes from right from the foot of the cross. It's the Lord God who laid down his life for us on the cross, even though we were sinners. You know, the strong laying down their lives for the weak, making sacrifices for the weak, that informs our medical and Western culture. But on the other hand, of course, we're living in a post-Christian society, a secular humanist society, where human beings are valued differently and where unborn children and elderly people with dementia, for example, are regarded as less important, less worthy of respect, and to a large extent disposable. And it's been shocking to see some of the appalling human rights abuses that have already taken place under the cover of this pandemic. Now, New Zealand, where I come from, has passed the most draconian abortion law just in the last few weeks to allow abortion on demand up to 20 weeks. They've done a similar thing through regulations in Britain. We have now a Domestic Abuse Act, of all things, going through Parliament, where they've tacked on amendments to liberalise the abortion law in Britain. And so, yes, I think there is hypocrisy, but there's an element of they know not what they do, because they're also on the other side expressing an ethic which is profoundly Christian, but they just don't recognise where it's come from. It's quite a bizarre situation.
And Ted, do you? What are your any comments on what Peter said there? I think there's some real insights there. There's a partial falling back on a Christian ethic in some of the response to this, and there's also some cynical moves. As a Canadian, you'll know that there was a rather cynical attempt on the part of the government to give itself almost 2 years of unrestricted tax raising and spending and borrowing powers without parliamentary consent. Unfortunately, there was enough in the opposition to resist that. How are you finding the sort of listening to some of the rhetoric, and how might you reflect on what Peter has said there?
Yeah, I would just agree wholeheartedly, and we certainly have this Marxist move in Canada here, and there are there are those in power that are trying to exploit this moment in time and to their own ends. And I would just also echo the confusion then about how people prior to this were viewing the elderly and the vulnerable people, and now how they've become the centerpiece of concern. And I champion that concern. They should be a certain centerpiece, and we should be concerned about the elderly, as Peter was saying, from our Christian legacy. And I'm hoping that perhaps when this settles, that will still carry through. That Christian perspective will still carry through in these people's minds, having gone through this so-called trench warfare, so to speak, that they will have a different sense of value for human life. This is my hope, that we'll not only wash our hands better and cough into our elbows better, but they will actually take care of the vulnerable better.
Yes. Okay, so guys, we're so thankful for the time that you've given us. I'm gonna just come to a final question, and I'm going to ask you both for a concluding comment. This has been immensely helpful and informative, and I'm sure that everybody who listens to this is going to be really encouraged, helped, and blessed by it. Let me, as my final sort of major question, let me throw a real zinger into the mix here. And let's remember, I'm not American. I'm actually Canadian and British. I have both passports. one of the things we're seeing, there's obviously political fallout from all of this in the Western world. There's even been talk of, can the European Union survive this outbreak? Can the euro survive? So there's questions in Europe. You've got public figures in the USA saying that life will never be the same. We're going to have to make fundamental changes. These people are often politically deeply influenced by Marxism and socialistic ideologies. So all of that kind of thing is going on. There's political fallout. But one of the things that has struck me as I've been listening to commentary and reflecting on it, and Peter, as a Brit myself, and you living in the UK, you know how important, almost, dare I say, and I'm not going to put words in your mouth, these are my words, how the NHS is, to my mind, something of an idol in Britain, and has been for several generations. I'm not talking now about the importance of healthcare. I'm talking about now the idea of socialized medicine. Without putting either of your careers at risk, can I ask this question? As myself as a cultural apologist, this one of my concerns for many years has been the prudential question of socialized medicine, what it's meant for the taxpayer funding abortions and euthanasia, as well as all kinds of elective surgeries to do with gender and so forth that are incredibly controversial today. And it's interesting that in most Western countries, abortions, which is surely an elective surgery, are still going on and still being funded by the taxpayer in this time of crisis. This raises, to my mind, certain questions about the extent of socialized medicine and our commitment to it in the West. In the wake of this situation, this crisis, I in a certain sense, I'm only seeing calls for it to be increased. It seems, listening to the British Prime Minister, especially when he first made the announcement about the lockdown, I watched his broadcast very closely. His appeal to the British people was to essentially save the NHS. And of course, we must be mindful of our healthcare workers. We've got to protect them. They're concerned with protecting us. That's not the question I'm asking. I'm really asking a question about, do you see any fissures opening up, any problems, questions that we might now ask in wake of all of this about socialized medicine? And are there private, public alternatives? Might there be pressure to now think through ways in which the private sector might become more involved in healthcare? You've both talked about the way in which the West was behind the 8 ball on this. Again, without wanting to throw either of your careers into total disarray at the conclusion of this program, any thoughts on I wouldn't hesitate to call the NHS, frankly, a national idol. And it seems that nobody wants Dagon to fall over and his head to fall off in this whole situation. Are there ways in which we could start to rethink the very, in my view, myopic way in which we've been approaching in much of the West? Not in America, of course. There's more of a mixed approach there, but this very socialized medical approach. Are there weaknesses to it in the wake of when you confront a virus like this and its fallout? So whoever dares tread into these waters, feel free to speak up first.
Go ahead, Peter.
Well, there are so many questions there, and obviously there's the huge political questions of right versus left, small state versus big state, whether things like health and education should be funded centrally or individually through insurance and other means. And I guess those are too complex. We might to get into in depth here. I think my comment would be, when it comes to the NHS, you've said an idol, and it's often said that the NHS is the closest thing Britain has to a national religion. And I think particularly at times like that, the reason for that is that people see the NHS at this moment as their salvation. And the slogan has been, go home, protect the NHS, save lives, because we see that the NHS is not going to be able to cope with this crisis unless we help it. And so the message is, you've got to help the NHS by social distancing, going home, flattening the curve, so that the load of cases that reaches the NHS is going to be manageable. And in the meantime, we're going to use all the time we've got to increase the capacity of the NHS by increasing the staff, increasing the ventilators, increasing the number of beds, and so on and so forth. So I think that there's one way in which I wouldn't rather be anywhere else in a crisis like this than with the NHS, where the government has the freedom to make all these decisions to increase its capacity and at this desperate stage to help us. But it's a much bigger question as to what the longer term thing is once we get through this. And the major crisis facing the NHS at the moment is that there simply isn't enough money available to fund it centrally. And one of the main reasons for that is because Britain, like many Western countries, is in an inordinate amount of debt. I mean, the whole, those of us who, perhaps I shouldn't reveal my colours on this, but as a New Zealander, perhaps it's inevitable. But I voted Brexit, and part of the reason was that
So did I. Praise the Lord.
Rather than the loss of sovereignty, I didn't want my laws being made by people who were not accountable at the ballot box, was a big part of it. But another big part of it was not wanting to be shackled to what I really saw as an economic corpse of Europe, a hugely indebted continent, which is not going to be able to go on. And I think from a bigger point of view, what we're seeing here, and perhaps the coronavirus might be something that puts the accent further to this, is, as I said, an end-stage culture. The West is in decline, and what we're seeing now in the world is the rise of the East, of China, East Asia, India, all these new states, the extension of building the new Silk Road and so on. And I think we're going to be living in depending on how long this goes on and what its effects are on the economy, we live in a hugely indebted world, and this is only just going to make things worse and raise tensions more. And as Christians, we really need to be living as the apostles and others in the first century were always living, even at that time, in the expectation of the imminent return of Christ, and seeing all of these things happening as signs of his coming. So it's a call for the church to preach the gospel, to call people to repentance, to live holy lives, to serve compassionately with the heart and hands of Christ, as Ted was saying, and to be salt and light in our society. And more than anything, I think this crisis should be calling us as Christians back to a conviction in the gospel, in our certain hope, in the fact that we do not fear death, that we know that God is utterly sovereign and that he'll work all things for good, even this virus, and be praying ultimately for his glory and for his plan for the world. So behind... They say that the Chinese character for crisis is made up of the two characters of threat or danger and opportunity. And behind every grey cloud of threat, there's a silver lining of opportunity. And I think that's the question that we should be grappling with as Christians, is what opportunities does this give us as Christian believers to love, to serve, to preach, and to be that city, that light on a hill, so that people would be drawn to our Creator and our Saviour.
Yeah, and I would just say amen to that, Peter. Well,
that's a powerful statement.
It's a brilliant brilliant note perhaps to end on. But as a lowly Canadian here outside of the UK, without the cool accent, I would just say that the Canadian position. I'm certainly a fan of the socialized medicine, and Tommy Douglas putting that forward for us. I think there's tremendous advantage there for us over other models. But the problem with being in Canada is that we're wannabe Americans in many respects. We follow Hollywood closely, and we follow what the Americans are doing in terms of their medical provision and all the toys they have and all the investigations and the techniques and the therapies, and we want what they have. So the grass is very much greener on the other side. We want what they've got, but we want it done in a socialized medicine scenario. And so we want the government to pay for it, but we want what they have. And of course, in the States, it's a very different scenario there, and they're very much paying for it. So it's really unfair for us to want what they have, and yet that this is the tension that's created. Now, the private sector is already involved and currently now with, for example, our blood services, because we're overwhelmed. But there may be a role for that involvement going forward. But I would echo, though, that patients in general do idolize medicine. It is seen as the savior, and I think this is a mistake. And I think sometimes we perpetuate this as doctors. It feels good to be with the Messiah complex, to come into a scenario and fix things, so to speak. But we have limitations, and I think we have to be honest with people of the limitations that medicine has. And medicine finally can't save us, and as nor can a self-help perspective, which is so popular in our current culture. So I think, as Peter was saying, we have to gently steer people to the one who can save. And really, this is not only an opportunity for us to be salt and light, but perhaps an opportunity for generalized repentance and a call to the one who saves.
I think, but both of you have made some really important and powerful points there. I think this whole notion that we are in an end stage culture in the West is something that, Peter, as you know, probably have been arguing for some time, a cultural decadence, a falling off, a falling away, and the debt levels that you mentioned, and of course the amount of debt, the sort of mortgaging of the future and of our children's future that's going on even in the midst of this crisis. Canada pumping 107 billion in sort of stimulus and bailouts that we don't have, piling on the national debt. The US with 2 trillion plus, and the billions in the UK. And I think that does raise important questions, and I think it will raise increasingly important questions about how we manage medicine going forward, and the idea of medicine as a savior. Again, I think the West has really, you're absolutely right, looked to that, both of you, pointing out as a kind of almost a savior, rather than looking ultimately to Christ. I'd like to see Christians in the church recover something of their role in providing various forms of care. As you both know, many of the hospitals in Europe and in North America were established and funded by the church, not by the state. And I think there's also an area, I think, that's a bit of a prison for us in Canada, in that we don't have the option in Ontario. I don't know what it's like in Alberta, Ted, because I know the health is governed provincially, but we don't have the option of actually having even utilizing private medicine if we can afford it. And of course, that puts additional pressure on the public sector. So those are all really big and important questions, and you've spoken to all of these issues very powerfully. Let me close then with this question for both of you, 30 seconds each. What advice then would you just give to the average Christian in their home today? You've talked about the importance of declaring the gospel. You've both talked about the importance of the call to repentance in the midst of this crisis. How can we best serve as Christians in this moment of crisis? As we sit here, most of us in our homes, most of us under some form of quarantine, how can we best serve one another? Peter?
Well, I think it's to realize that all the great benefits of medicine, as you've said, they will lengthen our lives slightly and improve its quality. But it is eternity that really matters. And I think the call to the church, as always, because judgment begins with the house of God, it's for us as a church to repent, to turn away from the things that we know that are wrong, and to live holy lives which commend Christ and speed his coming, so that we can be that light on a hill, that salt in our society, and uphold him in word and deed, preaching his gospel of salvation, and also demonstrating his love and compassion to a desperately hurting world. The writer of Hebrews talks about people being held in slavery by their fear of death. And I think what this virus is showing us more than perhaps anything is people being held in slavery by their terrible fear of death. And but there's something far more greatly to be feared than death, and something far more wonderful to embrace than life on this earth.
Yes. Ted?
Well, I would just say amen to that. And then in my closure, just read from Philippians 4. Rejoice in the Lord always. I say it again, rejoice. Let your gentleness be evident to all. The Lord is near. Do not be anxious about anything, but in everything by prayer and petition with thanksgiving, present your requests to God, and the peace of God then, which transcends all understanding, will guard your hearts and your minds in Christ Jesus.
Amen.
Well, Dr. Saunders in the UK, Dr. Peter Saunders, and Dr. Ted Fenske in Edmonton, we so appreciate you both wonderful friends of the Institute. We're honoured that you took the time today to join us in this conversation and also help the EICC present a thought through and balanced perspective on the issues for those that would be interested in what we as an organisation have to say. And we want you to know how much we appreciate your work and labour in the Lord in this area of medicine. And at a time like this, that sense of appreciation is heightened. So we really do thank you for joining us and for helping us today.
A real honor, Joe. Thank you.
Thank you. It's been a real pleasure.
Thank you for listening. We hope you've enjoyed this episode of the podcast for Cultural Reformation, brought to you by the Ezra Institute for Contemporary Christianity. If you did, it would mean a lot to us if you took a moment to subscribe, like, and share the podcast on social media and on your favorite listening platform. For more resources, please visit www.ezrainstitute.ca.